My name is Muzaffar Qazilbash. I am a professor of medicine at MD Anderson Cancer Center in the Department of Stem Cell Transplantation. I'm going to talk about one of our studies, which will be presented in the poster session this coming Monday on December 9th. We look at the outcomes of our myeloma patients, how they do after various treatments, and then we look at their risk factors, cytogenetic risk, disease stage, various induction regimens that they receive. But one very important area, both from our standpoint as well as from patient standpoint, and we get asked, what about the outcomes in different racial or ethnic groups, because there are a number of factors, whether they're biological factors or there are demographic factors. Sometimes it's the socioeconomic factors that can play a role in these outcomes. And if you look at the data, results are all over the place, but something that comes out in various ethnic minorities in the United States, some studies show that the outcomes have been a little worse. But then you look at the access to healthcare, the worse outcome sort of gets neutralized. So we looked at our database and we identified close to 2,000 patients, and our patients self-identify themselves as belonging to a racial or ethnic group. So out of those 1,960 plus patients, there were about 353 who identified themselves as African American. There were about 400 plus patients who identified themselves as Hispanics or Latino, and there were more than 1,100 patients, or roughly 60%, who identified themselves as non-Hispanic white patients. So we looked at their outcomes, and they all received stem cell transplant, and prior to that, they received induction chemotherapy with various regimens. And this was a study that was done over like 17 or 18 years. So we had a long follow-up across different treatment periods. So we looked at their outcomes. So first we looked at, was there any difference in characteristics of those patients besides their ethnic groups? So more or less they were similar, roughly the same age. They received similar treatments, except for patients who identified themselves as Latino or Hispanics. Fewer of them, fewer than 40%, actually received a combination of proteasome inhibitor and an immunomodulatory drug like lenalidomide, which was less than the other groups, which were more than 50% or 60%. Other than that, they were pretty similar. So then we looked at their outcomes, and our primary outcomes were what were their response rates. So again, in the patients who identified themselves as Latino or Hispanic, fewer of them had achieved a deeper response. Like about 80% had very good partial remission at their last evaluation versus 90% or so in the other two ethnic or racial groups. And then we also looked at progression-free survival. And in myeloma patients, over the period that they were studied, we saw that in African Americans, it was more than 4 years. In patients who identified themselves as non-Hispanic whites, it was more than 5 years. But again, those Hispanic Latino patients, it was only 3.2 years. So it was significantly shorter than other ethnic or racial groups. There was no difference in their high-risk status and all. So that one thing that stood out. There was no major difference in their overall survival, but definitely progression-free survival was lower in the Latino Hispanic population. And the only thing that we found in that group was that fewer patients received the optimal induction regimen. If that had a role to play, it's hard to tell in a retrospective data where patients had already been treated and there could be some missing information, other factors that we did not know. So these were basically the important results that in this group could be a hypothesis generating thing that others should look at their databases. There are CIBMTR, the International Bone Marrow Transplant Registry databases, where this question can be asked and see if others can verify these. But this was an intriguing finding, and we thought it was definitely worth presenting at the meeting. This was a retrospective data. I think one way of looking at it is look at other places also, that is it real or it just so happened in one center there were some flaws in the way data were collected that this. But if this comes out, then we have to identify the factors. That what are the factors? Is this a biological factor? Because again, there is no uniform Latino, Hispanic group. They're people coming from different countries, different backgrounds, different states who identify themselves. So one has to ask the question, is that a biological factor? Does this have to do with the socioeconomic status? Does this have to do with access to healthcare? Are these patients coming from the background where they do not make it to the major oncology, hematology centers, or they are not getting the optimal treatment because they do not have access to those? So those are the kind of questions that one needs to ask in the future. And again, if there are those factors, then again, this is more of a policy type of issue. But again, as physicians, as researchers, we need to do everything to basically improve access so that there is more equitable distribution of treatment, which hopefully will translate into better outcomes for those who have somewhat worse outcomes than others.